fifth part of CABG. Let us to continue with the weaning process from the mechanical ventilator. We can use CPAP, which is a continuous positive airway pressure, then the face mask, spirometer, also deep breathing and cupping exercise, support with pillow for the chest, and chest physiotherapy. Also, we have to assess the hemodynamic stability post-operative. We have to prevent myocardial stenting, which is severe myocardial ischemia. We have to optimize the preload, cardiac contractility, and decreasing the afterload. To maintain a preload, we have to provide the patient with adequate fluid. The contractility, we can give positive inotropic agent. To decrease the afterload, we can provide a vasodilator drug. Monitor arterial blood pressure, central venous pressure, pulse, pulmonary artery pressure, and cardiac output. The MAP in the first 12 hours should be range from 65 to 75 mm mercury. The MAP in the next 12 hours after the operation up to 90 mm mercury is acceptable. For the patient with hypotension, we can give dopamine and IV infusion, normal saline, and heat starch. For patient with hypertension, we can give vasodilator drug like nitrosine, which is arterial vasodilator, nitroprusside, which is a venodilator that act both on artery and vein to decrease afterload and preload, while nitrosine is decreasing the afterload and enhance the perfusion. If right atrial pressure increased, the preload increased, we can give inotropic agent to decreasing fluid intake and give vasodilator drug. If the cardiac output decrease, we can give the patient milirone, which act to increase the cardiac contractility, to increase the cardiac output, and making a vasodilation, decreasing the afterload, so that enhancing the cardiac output also. Cardiac rhythm, we have to monitor the electrolyte, especially potassium, edema in the conduction pathway, and hypothermia. All of these things may affect the cardiac rhythm. The most common type of arrhythmia after the open heart surgery is ventricular fibrillation and atrial fibrillation. Also, we have to monitor the chest tube and drainage for the amount, color, flow, which should be less than 200 ml per hour. In the first hour, the fluid depletion causes. هناك عدة أسباب لنقصان السوائل بعد العملية. Blood pass through the pulmonary bypass machine, the cell damage and release of bradykinin, which is a vasoactive substances, and the fluid leak into the interstitial space. In addition, the renin is released, decreasing the vascular space لأنه نهاية renin stimulation system, producing the angiotensin II, making a vasoconstriction. In addition, the patient may experience diuresis because of hemodilution and hyperglycemia. All of these causes may lead to fluid depletion after the surgery. Monitoring post-operative bleeding. Plavix should be stopped 5 days before the surgery. نوقف البلافيكس وقلنا البلافيكس هو anticoagulant. If chest tube more than 200 ml per hour, we have to provide a medical and nursing intervention that include we can give protamine sulfate 1 mg for every 100 unit of heparin. فإذا كنا معطين 5000 international unit heparin نقدر نعطي 50 mg protamine sulfate as antidote. Platelet infusion, monitor BT and BTT, may provide patient with the cryoprecipitate and factor 7 coagulation factor. Blood transfusion using fresh frozen plasma based on the result of BT. Warm patient. Platelet dysfunction also may lead to bleeding. Aspirin intake, intra-aortic balloon pump, bypass machine, all of these may lead to platelet dysfunction. If the BT more than 15 seconds, bleeding is related to the decreased fibrinogen, and thus we have to provide the patient with a blood transfusion that contain FFP, which is fresh frozen plasma. If the bleeding is more than 500 ml per hour, surgical cause and the patient needs reopening. Graft failure وفي internal bleeding في pleural bleeding في bleeding that is serious and need to be stopped during using reopening surgical technique. Obtaining body temperature and rewarming patient. If the body temperature is less than 36 لأنه الهايبوثيرميا قلنا إلها negative effect. Using طبعا كم ندفيه using thermal blanket, lamp, warm, humidified oxygen. Measuring urine output hourly, and the urine output within the normal should be 0.5 ml or cc per kg per hour. The normal urine output for the adult patient هو عبارة عن نص مل لكل كيلوغرام في الساعة. فإذا المريض وزنه 70 كيلوغرام هذا يعني إنه لازم يطلع يورين 35 مل كل ساعة. إذا مريض وزنه 100 كيلوغرام لازم يطلع 50 مل per hour. Obtain chest x-ray, ECG, routine work, ABGs, hemoglobin, potassium which should be more than 4 ml equivalent, BTT within 15 minutes of arrival. We have to assess the neurological status by pupil react to the light and in the midline. Assess the skew 1 hour. Squeeze the nurse hand. Yes, no question. May we use to ask question for the patient using yes or no question. يعني إذا الممرض أراد أن يقيم وضع المريض العصبي أو neurological status, we can ask him or ask the patient some questions. The answer should be yes or no.